The title is Pain in Depression, How Relieving Pain Will Improve the Outcome of Depression.
Thank you, Chairman. Ladies and gentlemen and colleagues, thank you very much for the committee who have invited me to come to this lovely meeting. I'm Andre from Department of Psychiatry in Indonesia and also the Psychosomatic Clinic in Omni Hospital, Indonesia. And today I'm going to talk about the pain in depressions and how relieving pain will improve the outcome of depressions. I think most of us are clinicians, and we know that in our clinical practice, sometimes we face the problems with depressions, but not only in the very beginning of time that there is mood symptoms in the first appearance of the patients, but more like physical symptoms. And I know that most of us are physicians, but not all psychiatrists. So today, I just want to remind us again about maybe the changing conceptualizations of MDD from today, difference from the past, that in the past maybe we don't know exactly what is going on in the brain related to the problems of depressions. But today we know that the cellular pathology and also the interplay of biology and environments has been a very, kind of improving and also concerning research in our field as a psychiatrist or even as a psychosomatic medicine specialist. So just want to remind us again about the multiple core of associated symptoms of depressions. And we know that maybe in our clinical practice, we very familiar with the patients with depression in mood symptoms. But do not forget, sometimes patients that come to our clinics, even now in the internal medicines or in neurologic departments or even in GP's rooms, not only for the for the mood symptoms, but also for the associated symptoms like, kind of brooding, obsessive ruminations, and also the pain. And it is sometimes because the pain is not very concerning that patients will not go straight to the psychiatrist, but I think they will go to the GPs first or the neurologist to their pain or symptoms. And because we know that, as I said, as I heard from the previous speaker also, that the biology of major depressive disorders now is, kind of a upcoming research for today. And we know that this is not only about the brain. This is also related to other symptoms of the systemics of the functional of the body. Also related to the neuroendocrine system, the autonomic, and also the immune dysregulation. So talking about depression now is not only talking about the emotion problem, but also talking about the physiology of the body and also the connected to the brain itself. So it's very surprising, actually, from the studies that we know that most of the patients with depression, sometimes they complain also about the pain symptoms. And the studies say that more than about 65% patients with painful symptoms is more than compared to the patients without a painful symptom. So it is a very kind of like information for us that patients sometimes acknowledge not only the symptoms of depressions, but also has the symptoms of physical problems. So this is the case from the clinic that we very often see the patients with this kind of problems. They come with the major depressive disorder sometimes, but also they complain about the aches all over his body. I work in the psychosomatic clinic in my hometown, and many patients with this kind of problems we see every day. And in 2013, we conducted a survey for the patients, about 1,435 patients, that they they have to fill the form of Bradford Somatic Inventory, and we see that most of the complaints of the patient with depressions, not only the symptoms of kind of mood, but also the problems with pain. Actually, probably they complain also about the gut symptoms, aches, and also the back pain, or sometimes with the fatigue like that. So this is studies that say that approximately 2/3 of patients with depressions in primary care present with somatic symptoms. So this is also the study that we can see that the chronic pains in major depressive disorders and also the general anxiety disorders, if we see patients with many complaining about the pain or about the painful symptoms of the body, maybe they have more aggressive symptoms compared to the less complaining about the somatic symptoms or pain problems. And unfortunately, from the study, we know that if we treat the patients with mood disorders or maybe depressive disorders only, sometimes we can see that the physical symptoms do not respond equally to the depressive symptoms when we treat the antidepressant treatments. We know, I don't know, here most of the patients with depression in China, or also in all over the country, what they give. In Indonesia, we very often give them an SSRI. Sometimes we can give also the amitriptylines, but the amitriptylines sometimes we are very afraid about the kind of like side effects, or sometimes they can also the problem related to the heart symptoms. So it is the close association between painful symptoms and depressions, also the need to emphasize the progressive treatment strategies, not only giving the standard basic of antidepressants, but also can be very aggressively talk about more symptoms of depressions that related to pains, and also how to treat well, so the patients will get better improvement with the kind of treatment. This is also the stress that in the previous, I think the talk of the professor in his morning sessions, it said that the residual symptoms from the Florence doctor, I forgot the name, the residual symptoms of MDD is sometimes often physical, not only the mood disorders, problems related to the mood symptoms. So I think it's more than 90% of the physical symptoms that patients have and complain about it in after the residual symptoms of depressions are often physical symptoms. And it said also the unexplained, severe, explained and unexplained physical symptoms, it can be very competitive. So we know that the severe unexplained physical symptoms is sometimes more than the explained physical symptoms. And it is also said that the painful symptom severity is associated with poorer depression's outcome. So I think we know that when we treat patients with depressions and we only focus to the focusing of the kind of like reducing the mood symptoms will help patients, but not a lot if the patient's also complaining about the physical symptoms. And surprisingly, also in the evidence and also in the studies, that pain can predict time to remissions of depression itself. So the patients without pain has more improvement in the remissions compared to patients with pain. So it is quite very interesting, because sometimes we are as psychiatrists more focusing about how to treat the patients of depression treat the symptoms, treat the mood symptoms, because we know that until now DSM-5 also acknowledge only about two kind of symptoms of depression, and more stress about the mood and also the kind of like a feeling symptoms, not the physical symptoms. And we see from the others batteries of when we call ask the patients with some of the tools that we have in our clinic, it's very seldom we stress about the physical symptoms of the patients of depressions. We more concerned about the mood symptoms of depressions. But I think we have to be very careful now. We have to be very more stressed about the problems with depressions, or also related to the pain. And this is also the slide that have clear in mind that pain symptoms improvement will increases the chance of remissions. So how about the pain and depressions? We know that pain is related to the subjective feeling, and we know that this is amplifying in the brain related to the norepinephrines and also the serotonin neurotransmitters that we have already know has so much playing role in our depressive theory. So the problem is when we see the patients with depressions, when we want to get a treatment for depression, symptoms of depressions, we focus on the serotonins only, not on the other neurotransmitters of the brain. So we know that not only drugs that can manage the treatments for the patients with depressive or patients with depressive and pain, because there are so many multimodal treatments related to the not only for the treatment, but also can be educational. We can stress management, lifestyle management. Some of them may be using a biofeedback. And also don't forget about the physical therapy or occupational therapy, because there's an increasing amount of researchers that concentrate how to relieve pain and also depressions by giving them exercise. So I think we have to be very concerned now about the relationship between the patients with depression and how to treat the patients with depression, and the normalizations, not only the serotonin, but also the serotonin and also the norepinephrine that play so much role in the prefrontal cortex and the limbic system that related to pain and depressions. And because we know from all most of the studies that the rapid remissions of depressive symptom is the most important, that predict for the favorable long-term outcome. Because we know that in our clinical practice, when we treat patients with depression, sometimes they get only 50% of remissions, and they can coming back again to you with depressive problems and also the pain problems itself. So for the summary, I think the psychiatrist has to be aware of pain symptoms in MDD patients, but I think because many of us also know that we work in the GP's practitioner, we work in the kind of like internal medicine or neurology department. We can see that the painful physical symptoms are commonly associated with features of major depressive disorder, and because we know that painful physical symptoms has been associated with the poorer treatment outcome, so we must acknowledge in the first place, and we have to be very careful when the patients come with depressive symptoms, and also we have to. So in my clinics, many patients come to me as they complain about TANS, they complain about the back pain, and they complain also about the fibromyalgia symptoms. Some of the colleagues say that the fibromyalgia is like a dustbin diagnosis in the medical field, but be careful with that kind of symptoms, because we know that sometimes when we treat patients better with the patients depressive and the pain, we can get the more outcome, we can get more the better outcome for these patients. And patients with MDD who have improvement in pain are more likely to achieve remissions compared with patients who do not have improvement in pain. Thank you very much.
Any question? I have one question.